Hi everyone. Today's lecture is going to be about how we breathe for people on a ventilator using pressure breaths. This is an introductory talk. I'm going to do a more detailed discussion of pressure breaths later on. The pressure breath is one of the easiest ventilator breaths to understand because it's how you and I breathe. And it also reminds me always of the old experiment we did in elementary school where you cut a 2-liter soda bottle in half, hook a balloon up to the inside, and then tape a balloon to the bottom. And you see that both positive pressure, inflating the balloon with your mouth from the top, and negative pressure, pulling the balloon down on the bottom, will inflate that middle balloon. That's really similar to a pressure mode of ventilation where instead of using our diaphragm to pull the balloon down and inflate the lung, we're using positive pressure to inflate the lung. So if we look at that on a picture, we have a fixed pressure that's going to go on and be turned on by the ventilator. So in a pressure breath, the pressure is fixed. It's set by us. We do this over a PEEP, which I'm not going to talk about today, and then we deliver, again, a pressure. When we talk about pressure breaths or breathing for people, the default conversation should be that we're talking about control modes. And in control modes, we set the inspiratory time. And so we turn on the pressure, and it stays on until a time that you also set. Now, when we're fixing the pressure, the flow, the amount of air that's actually delivered, is variable, and it's variable based on the patient in front of you. So here, at the start of a breath, you're going to apply a fixed amount of pressure, and at the start of the breath, your lungs are very compliant towards breathing in. And so at the start of the breath, you'll get a lot of airflow for the same pressure. Now that my lungs are full, I don't have a lot of space for air to go in. My compliance has gone down. So if I apply the same amount of pressure, the airflow will go down. And similarly, the pressure in the lung is now more positive. It's equilibrated between the ventilator and the lung. And so how much pressure downhill we're going, that goes down because the pressure in the lung is equilibrating to the ventilator. And my lungs are stretched out and not very compliant. And that gives us a decelerating flow pattern on the ventilator, which we see here. Then the vent turns off and you breathe out. And that occurs in the opposite direction. When you start breathing out, your lungs are compliant towards breathing out. They're full. The chest wall is pushing in. The lungs are stretched. They want to deflate. And there's a big pressure gradient between the now positive pressure of the lungs and the atmospheric pressure or the PEEP of the ventilator that you're breathing out to. In all these situations, the flow is variable, and it's always variable based on that old physics principle, V equals IR. And the sum of this is that it's variable based on the total compliance of the patient in front of you. And that's going to include the compliance of the lung, which we always think about when we're treating somebody that needs a ventilator. But it's also the compliance of the chest wall and of the body and of the patient. If the patient squeezes their chest and is mad at the ventilator, it's going to be hard to get that breath in. If they're a really large patient with a lot of abdominal weight pushing on the diaphragm, if you lay them, say, head down, it's going to be hard to move that abdominal weight off of their lungs. And so all of these things combine to give you the actual airflow delivered by the ventilator. I always think of that with the V equals IR equation, the voltage gradient or delta V being the difference in pressure between the ventilator and the lung, current or I being airflow, and R being resistance, or if you like to think about it as compliance, the inverse of compliance. The lungs decelerate, like we talked about, using this relationship. As your lungs fill up with positive pressure, the delta V, the driving pressure between the ventilator and the lung, it decreases because the lung's filling up with that positive pressure. And again, as your lungs fill up all the way, they're really stretched out and the chest wall pushes back. They are not compliant. So the flow or the current goes down. It's important to also remember that when we talk about flow, it's in milliliters per second. But if we multiply that by seconds, you get the area under this curve. And if you fill that in, that equals the tidal volume. Mils per second times second equals mils. And so whenever you're trying to get a bigger tidal volume, you're just trying to make this thumbprint bigger. Here's an example of a pressure breath on a ventilator. We see that the pressure turns on. It delivers that pressure for a set amount of time that we've picked, and the airflow decelerates a little bit. This picture actually has a desynchrony, which as you go through the different lectures I do, you'll hopefully be able to notice. It's a little bit subtle here, but it's definitely present. Again, pressure control controls the inspiratory time. You turn the pressure on, and it delivers that pressure for a set amount of time. So you can make mistakes and do things like increase your inspiratory time way too long for the patient in front of you. Does this change the initial slope of your airflow? Of course not. V equals IR doesn't change. Does it change how far down it goes? Of course not. But as you notice, your flow keeps going down, and eventually the pressure of the ventilator pushing air in equals the pressure of the lung pushing air out. And what happens when you have a really long inspiratory time is you've given the lung enough time to equilibrate. It will sound like this. And then the pressure in my lung equals the pressure of the vent. And you sit there. That's called an inspiratory pause. Inspiratory pauses, when I ask about them in lectures, I always hear that these could be dangerous. But they're not maybe too dangerous in the way you think about it. They don't add pressure, so barotrauma is less likely, and similarly, they're not going to add pressure in air where pneumothorax becomes a problem because you've set the pressure. And really, the amount of air going in by that extra little bit of time is not much. The problem is that we ventilate people with small tidal volumes and high respiratory rates, and we don't help them breathe out. So if you're spending all of your time breathing in because of these inspiratory pauses, you may run out of time to breathe out. And if you run out of time to breathe out, which happens a lot in our sick patients that have asthma, COPD, or that have ARDS, you may air trap. And if you air trap on pressure breaths, you're going to keep getting more air in the lung that doesn't leave. So if I breathe in and hold it, now I breathe out half my air. And then if the vent decides it's time to get another breath, you get less breath because your lung's already partly filled, but now you're starting with a full lung, and you breathe out partway, and then you breathe in again, and pretty soon you don't have any breathing really happening, and you just sit there with full lungs. That's very bad for getting blood back to your heart, and it's very bad for actually clearing CO2. It's also uncomfortable. Here's an example of an inspiratory pause. I obviously am not going to show you a picture of a air trapping patient because that's not really that safe. Here we can see that we're delivering a pressure for a set amount of time, and here's the flow. It goes down to zero and there's a pause. This can help you ventilate and increase your mean airway pressure a little, but you have to make sure you're not limiting how much time you breathe out. And in this case, we've got lots of time to breathe out. And here we go, riding. So this isn't really a problem, but it is an inspiratory pause. In contrast, you can shorten the inspiratory time too much. And here, We can turn the pressure on and look at a normal breath, and then we can turn the pressure on and cut that breath off really short. What would happen? Well, the initial flow is not going to be very different. The slope is not going to be very different. But instead of keeping on going, we're going to cut it off really early. That's what that looks like. So if we look at the tidal volume between these breaths, you see that the tidal volume of the first breath is a lot bigger than the tidal volume of the second breath. How can we get a bigger tidal volume if we've messed up the I time? If you don't recognize it, there's not much you can do on the ventilator except to go way up on the pressure and spike that flow up higher here, which could be dangerous and certainly makes you look bad. You're giving a lot of pressure for the same amount of tidal volume. Is this bad? Well, there are some downstream consequences, most of which is at the ego level. It can be uncomfortable, you can limit your minute ventilation, and you're trying to fight yourself a little bit with the ventilator. This is what that would look like to correct it. I've tried to make the area under this curve, the tidal volume, about the same here between the last one. The only way to do that is to bump up that pressure. When I look at inspiratory time, I always think to myself, first, do I have enough time to breathe out? And second, can I gain free tidal volume by increasing the time? When I say free, what I mean is tidal volume without increasing the pressure. So for the same pressure, can I get a bigger breath? If you increase the I time, you can do that most of the time. A lot of us intensivists disagree on how far out you want to breathe for patients, like what inspiratory time you should target. In general, if I call that peak 100% and I try to decrease I try to watch the flow pattern once it gets down to around 25%, that's normally good, where I'm getting the bulk of free tidal volume and I'm still allowing time to breathe out. If I go up on my inspiratory time on this last breath, I'll get a little bigger breath, but not that much. A little bit of diminishing returns. So I aim around 25%. Other people disagree. That's okay too. What happens on a pressure breath if somebody works hard or works with you? Well, the pressure is set by us, so that doesn't change. What happens to the waveforms? If we go back to our V equals IR and we remind ourselves that resistance includes both the lung and the patient, then you know that if the V stays the same but the resistance goes down, the ventilator doesn't have to move the chest wall. You're helping the lung expand. The flow is going to go way up. This is pretty simple to understand, and it looks like this. Everything looks the same, but you get more airflow. When I look at these pictures, I always think it looks like skiing down a hill. Whether you're working or passively there, you have this nice slope downward. And that's it. You're just skiing down a hill. But if you have a patient who's working really hard to breathe, it can look different. And what it looks like is this. The patient's sucking in air so they get more airflow during inspiration. So it sounds like this. Lots more flow that's sustained. Instead of skiing down a hill, I think of this as jumping off a cliff. Here's an example of inspiratory work of breathing on pressure control. Pressure goes on, it turns off at a set time, and in the middle you see this sustained inspiratory effort before they breathe out. And you notice here they breathe out with this long, continuous exhalation, not this nice backwards skiing down a hill. Something's not right with this patient. Working hard in, taking a long time to breathe out. We're not doing very well for this one, and we should try to look at what's causing these problems. Whenever we're on a pressure mode of ventilation and delivering pressure breaths, we want to ask the question, how do I get the most volume for the least pressure? Or, simpler way to think about it is, how do I increase the tidal volume in a pressure breath? Well, I always just go back to my V equals IR. And if we look at that, I can get a bigger breath if I increase the pressure. That's the simplest first thing to do. And again, that just looks like this. More pressure gives you more airflow. You're going to shift how long you can give a breath before you get that inspiratory pause. Everything gets bigger, much bigger breaths. It's also important to remember that we can manipulate resistance, and it's not always done by, say, treating pneumonia. We, of course, want to treat pneumonia and the underlying things like ARDS or bronchospasm, but you can do even simpler things to decrease the resistance. Things like if the patient's large and has abdominal weight pushing on their diaphragm, we can sit them up, and now the vent doesn't have to move that weight. Similarly, if they have a lot of edema in their chest wall and in their lung, we can diurese them. That's all extrapulmonary and intrapulmonary things. And finally, we can wake them up or pick modes that are synchronous to them, and they can help you breathe. So now the patient's muscles are moving their chest wall, and the vent doesn't have to do that. All of these will simply get you more flow for the same amount of pressure. Worker breathing, of course, is a little modifier to that, where instead of skiing down a hill, we'll jump off a cliff. And finally, you can adjust the inspiratory and expiratory times. People get this wrong all the time. Don't assume it's correct. I'd normally target what I've shown here. If I call the peak flow 100%, I keep the breath going and target an inspiratory time cutoff around when the vent or when the breath is about 75% done. So 100% height, 25% height. That's a good amount of time to breathe in while maintaining enough time to breathe out. When we mess with the inspiratory times, we lose out on free tidal volume. Again, don't ever forget that you can get free tidal volume out of that time. That's it. That's introduction to pressure breaths, and they're used in a bunch of ventilator modes. All the smart pressure control modes like PRVC, PCV-VG, of course pressure control modes, bilevel and APRV modes use the same physiology, and pressure support modes are the same with one tiny adjustment to this. We'll talk about that another day. Happy ventilating.